Hello everyone, welcome to another interesting episode of the Anti-Pharmacist podcast. I also welcome you to a new week. We will be continuing the drug use series today by discussing drug use in pediatrics. I decided to do this series as a progression because it just makes more sense to me that way. You know, from conception and pregnancy to birth all the way to old age. That is, in fact, the normal progression of the human life, right? A very big thank you to listeners who have been commenting on the previous episodes of this podcast. I really appreciate your beautiful comments. They have made me smile one time or the other. Now, about drug use in pediatrics, otherwise known as children. Infancy or childhood is a critical time in any individual's life. It is the time of the highest rate of development, and most children are not in control of what they consume, as they are not old enough to take such decisions. Indiscriminate use of medication in children can have consequences, which is why utmost attention should be paid to this. The irony is that it is not only the things that these children are given to swallow directly that affect them, even what the mother consumes can affect them, especially for breastfeeding mothers. This will be discussed in another episode, alright? So, if you have an infant or toddler, or you know someone who does, this episode is for you. Without further ado, let's get right into it. Pediatrics is actually a brand of medicine which deals with treatment of children and adolescents. Sometimes the word is used to refer to people in this category, that is the children. Now, this category of people fall into 6 age groups between infancy and early adolescence. They are neonates, which is from birth to about 1 month. Then there are the infants, who are between 28 days and 12 months old. Toddlers, who are between 13 months to 2 years old. There is also those in early childhood, between the ages of 2 to 5 years, as well as those in middle childhood, between the ages of 6 to 11 years of age. And finally, the adolescents, who are 12 to 17 years old. From this categorization, you would have noticed that there are variations in these age groups, which makes drug use and administration in them even more sensitive. It would interest you to know that drug treatment in children differs from that in adults, because pediatric dosing is usually based on weight or surface area, although sometimes it can be based on age. So, it is wrong to extrapolate pediatric doses from adult doses. Most people believe that children doses are just half of adult doses, and that's it. Now you know that it is very wrong. Doses and dosing intervals differ in children and adults because of age-related variations in drug absorption, distribution, metabolism, and elimination. Children's organs are still developing, especially the organs of metabolism and excretion, like the liver and kidneys, so one has to be careful. As for distribution, higher doses per kilogram body weight of water-soluble drugs are usually required in younger children because a higher percentage of their body weight is water. Also, many drugs bind to proteins, primarily albumin and some other proteins like the alpha-glycoproteins. Protein binding therefore limits distribution of free drugs to the body. Protein concentrations are lower in neonates but approach adult levels by 10 to 12 months. Mind you, also, absorption of medications from the GIT can be affected in children by gastric acid secretion, microbial flora, intestinal motility, most of which are reduced in children. All these pharmacokinetic parameters are not static. They vary as these children get older. While some increase up to a point and they start to decrease even before adolescence or adulthood, others continue to increase till they become adults. That's as far as I would like to go as regards the science of drug use in children. At least I believe I have been able to make you understand the reason behind the practicality of what I'm going to share on this episode going forward today. You see, most drugs have not been adequately studied in children. Only recently have regulatory authorities given allowance for some controlled clinical trials in children. And most of these medications are probiotics, which are not expected to have dangerous side effects. Children are generally subject to the same adverse effects as adults, but they have increased risk with certain drugs because of differences in pharmacokinetics as discussed earlier, or because of the effect of the drugs on growth and development. So I'll be giving you examples of medications that are contraindicated in children, that is, that should not be used at all in children, or to be used with close monitoring, or to be used to a lesser extent, because it can cause various toxicities or adverse reactions, which I'll also be mentioning. This will be based on commonly used medications, alright? And I'll put the drugs in classes based on what they are used for. First, let's talk about antibiotics. Examples of antibiotics that should not be used in children are ceftriaxone. It is actually an injection and it causes jaundice, that is the yellowing of eyes in neonates. It also causes a condition called kernicterus, which is a kind of brain damage which may result in intellectual disability, cerebral palsy, and neurologic impairments later in childhood. Another antibiotic contraindicated in children is tetracyclines. The drug doxycycline is also a tetracycline, okay? Tetracyclines cause discoloration and pitting of tooth enamel, and this discoloration is usually permanent, so it should not be given to children below 8 years of age. Chloramphenicol, on the other hand, which is another antibiotic, should be avoided in children because it causes gray baby syndrome, which is a type of skin discoloration in neonates. Some would wonder, is this not the same chloramphenicol eye drop that we use for our babies when they have conjunctivitis, which is commonly called Apollo? Well, the eye drop is safe because it is a topical preparation which is only instilled to the affected area, which is the eye. There is minimal absorption. However, caution should be taken to ensure that it is used as prescribed or recommended. You must take care not to use them beyond recommended dosage, which is usually 1 drop every 6 hours, because even though it is still a topical medication, it can be absorbed systemically to an extent, right? The eye ointment can be used as well, and the same thing applies to that. Fluoroquinolones like your ciprofloxacin, levofloxacin have also been known to be contraindicated in children due to evidence from animal studies which shows that they can cause cartilage toxicity. But this adverse effect has not been found in humans yet. The fact that they have not been found in humans does not mean that they may not happen. Do you understand? So, short-term use may be safe upon the advice of a doctor, especially when there are no safer alternatives for your child's condition. Another antibiotic, gentamicin, eye drop or ointment, however, should be avoided in neonates because it can cause severe ocular reactions. I have told you the age group of different categories of children, right? So I assume that you understand what I mean when I say neonates. Gentamicin injection is also contraindicated in neonates as well, as it can cause hearing loss. Other antibiotics to avoid in neonates are the macrolides like erythromycin, azithromycin, which cause digestive disturbances in children less than 6 months, and another antibiotic called nitrofurantoin, which causes hemolytic anemia, also in neonates. I think that's enough about antibiotics, right? On to the next class, which are the pain relievers, otherwise known as analgesics. Pain relievers are used often in children because they are prone to fever and various types of pain. In general, anything stronger than paracetamol, that is the acetaminophen, or ibuprofen for children over 6 months old, or diclofenac for adolescents should be avoided. The types of codeine containing pain relievers like cocodamol or tramadol, opioids generally, should be totally avoided. because they can cause respiratory depression, leading eventually to death. Aspirin is another pain reliever, which is an NSAID. It should not be used in children because it has been linked to Ray's syndrome in children, which causes swelling in the liver and the brain. It comes with symptoms like confusion, seizures, and loss of consciousness. Although aspirin is approved for use in children older than 3 years of age, children and teenagers recovering from chickenpox or flu-like symptoms should never take aspirin. Children are known to come down with gastrointestinal disturbances like diarrhea and constipation. In case of diarrhea, you should not use loperamide, which is an anti-diarrhea, in children less than 3 years of age, as it causes bowel obstruction in children. Some people also like to give their children mixed kaolin for diarrhea, but this can result in constipation in these children. Usually, oral rehydration, known as ORS, is sufficient to treat diarrhea. However, if there is evidence of bacterial infection, antibiotics can be added by your healthcare provider. As for constipation, avoid use of mineral oils like liquid paraffin, especially in children less than 1 year of age. It can cause lipid pneumonitis, that is fat collection in the lungs of children. Also, although castor oil is relatively safer, it should not be used in children less than 2 years old without a doctor's consent who would have weighed the risk-benefit ratio. Even in children between 2 and 12 years old, only a single daily dose of 5 to 15 ml, that is 1 to 3 teaspoons, is considered safe. Safer alternatives for treating constipation in children are lactulose or giving them more higher fiber foods and plenty of water. Moving on to antihistamines, which are used to treat allergies, hay fever, rhinitis, itching, sneezing. These illnesses are very common in children, especially because their immune cells are still developing, which makes them prone. Some of these medications cause drowsiness as a side effect, and some parents even give them purposely because of this. Antihistamines like cyproheptadine and chlorpheniramine are in this class. While chlorpheniramine, otherwise known as Piriton, may be safe for use in children above 1 year old, it should not be abused and turned to a sleeping medicine. Also, cyproheptadine, that most people know as Ciprigold or Cipron or Super Appetite, has been used to induce sleep or boost appetite in children. These are just side effects of the medication. Continuous use for this can result to hyperactivity instead of causing the intended drowsiness. In toddlers, it can even lead to respiratory depression and death during sleep. As for other common antihistamines like loratadine, diphenhydramine, which is usually in cough syrups, cetirizine, they should not be used in children below 2 years of age because of various side effects that they exhibit in this age group. The antihistamine nasal drop, xylometazoline, commonly known as Otrivin, although approved for use in children and infants, should actually not be used in babies less than 1 year old because it can cause drying of the nasal passages. Using saline nasal drops is safer in relieving stuffy nose in young children. Other medications worthy of mention, which are to be used with caution in children, are corticosteroids. Although they can be used in children upon prescription or recommendation for conditions such as asthma, allergic reactions, or some autoimmune diseases, they should be used strictly according to prescription because they can cause immune suppression and metabolic abnormalities even in adults, stock of children. However, there are some medium high and very high potency topical corticosteroids that should be avoided in children, especially those less than 1 year, because they can cause adrenal suppression due to their high rate of systemic absorption in children than adults. Examples of such are betamethasone ointment or cream, triamcinolone ointment, and 0.2% hydrocortisone cream. So if you're getting hydrocortisone cream for your baby, maybe because of his skin condition, 0.1% is just fine. I mentioned this in particular because it is quite common. Let me do a quick recap, or should I call it a summary for your understanding, because I know I have said a lot on this episode. I have mentioned that children's medication doses cannot be extrapolated from adult doses with reasons, and I have also mentioned drugs that are inappropriate for certain age groups in children with the risk or consequences involved. But all this is not to say that there aren't children who actually take adult doses of medications. I have explained that weight and surface area are major parameters and determinants of dosing in children, not just the age, especially for antibiotics. So this is to say that there are children whose weight differ from other children their age, and who, if given the same dose as those children, may actually not get the benefit from the medications. This applies to those children below and above these weight ranges. In other words, the best practice for parents is to know the weight of their children, because you may be required to produce it at any point in time, especially at the pharmacy. And if you don't know it, not to worry. There are usually weighing scales in pharmacies with which their weights can be measured at little or no cost to you. For every medicine administered or prescribed to either adult or children, the risk-benefit ratio is usually weighed. I've mentioned this several times on this podcast. Those effects of giving the medications I mentioned earlier to your children are risks. They may or may not happen. Or isn't it better to avoid them than to wait to see if they happen or not? So, if you see any of the medications that I've mentioned as contraindicated on the list of medications for your child or children at any point in time, be sure to ask the recommender or prescriber for clarification. They might have just weighed the risk-benefit ratio, and maybe they have found that there is no better alternative for your child's condition at that point. Alright? Wow, it's been a roller coaster of information here today, and I'm certain that you have gained a lot from it. Let me give you the chance to go listen again to this episode and digest all that I've said. Alright? Next week, I'll be talking to you about drug use in breastfeeding mothers, like I mentioned in the beginning of this episode. I'm sure that you wouldn't want to miss that as well. Thanks for listening up to this point. Let me go and rest my mouth because I've been talking for a while now. Please keep supporting the podcast with your follows, your likes, shares, subscription, comments, and all of that. They are very much appreciated. Till next time, stay healthy and